this spotter?
Yeah, sir. This spotter, first 4 questions you will be asking to team 1. Umar sir will be asking 4 questions to team 2. And Bubiti Naik sir will ask 4 questions to team 3. And Salab Kumar sir will ask 4 questions to team 4.
Okay, madam. Thank you. So to start the session for the questions for the team 1. So both the members of team 1, look at the image carefully.
Yes, sir.
Look at the image carefully, which is given. Take maybe 30 seconds to see the image. Then I'll start my questions.
Yes, sir.
Okay. So the first question is, what is your spot diagnosis? Give the complete diagnosis for this condition. This is a 21-year-old girl. Some background I'll tell you. This is a 21-year-old girl with this condition. Okay. Now you give your spot diagnosis complete.
Sir, this is a type 3 Pittsburgh classification fistula, anterior fistula at the junction of the hard palate and soft palate. In other classification, it comes to 3A, which is more than 5 mm, a large fistula in the anterior part.
Anything else you want to add with your diagnosis? We are expecting a complete diagnosis. So anything else you would like to add? Okay, we'll not tell the answers. We'll go to the. Do you want some more time, or I'll go to the second question?
With exposed vomer.
Sorry, tell again.
With exposed vomer.
With exposed vomer. Anything else? What is visible? Comment on that.
Nasal and inferior turbinates. The nasal inferior turbinates. Nasal lining is also.
Okay, we'll go to the next question.
Sir, better you, are you satisfied with the answer? Or you want to tell the answers at the end? Because they have to put the marks. Judges has to put the marks.
Yeah. Madam, I will not tell the answer because some questions may be related to the next questions also.
Okay. When you want to tell?
Maybe in the last we can tell 2.23 points on that.
Okay.
After all teams have completed.
Okay.
Okay, the judge will decide on the marks. Depending if you're satisfied, please give your answer as the marks. I'll go to the next question, madam, and to the team 1. What symptoms are commonly associated with such a case? When a patient presents with this condition, what are the symptoms associated with this condition? Team 1.
Nasal regurgitation, hypernasality, frequent URTIs, speech abnormalities, and feeding problems.
Okay, so it is a 21-year-old female, so she must be coming with some specific thing. No? So now we
nasal regurgitation of feeds.
Sorry, tell again.
Nasal regurgitation of the of liquid mainly.
Nasal regurgitation of liquids with other symptoms. Okay, now we'll go to the third question. How does the size and location influence the severity of symptoms? In conditions like this, how do the size and location affect the severity of symptoms?
Sir, the smaller fistulas can be expected to heal spontaneously, but the larger fistulas will definitely require a repair. And with the larger fistula, the amount of local tissue available for repair will also decrease.
Okay, I'll just repeat that once again, just a minute. How does the size and location influence the severity of symptoms? We're talking about the symptom severity, not about the treatment at the moment. So what differences will have in different kind of fistulas as far as symptoms are considered?
With larger size, nasal regurgitation and fluid incompetence complaints will be higher.
Then,
with a smaller fistula, it will be more towards hypernasality and speech rather than feeding problems.
okay, this is related to the second point.
Size.
Size or location?
Size, sir. And location more anteriorly, also the nasal regurgitation regurgitation also will be more compared to posterior.
While in posterior, there will be speech abnormalities, hypernasal and nasal air escape will be more in the posterior fistulas when compared to anterior fistulas.
Okay. So now we'll go to the fourth question to team one. So what are the options to temporarily close this gap?
For temporary closure, we have obturator, sir, which bridge the gap and keep the two areas separate, the nasal and the oral areas.
Okay, and when do you want to close the gap temporarily?
During feeding, if patient has excessive URT, more symptoms and
Mostly during feeds.
No, this patient has come to you. Now you will give them the choice of closing the gap temporarily. So what would
Yes.
be the situation where you would give them this choice?
Sir, when all the rest of the options have been exhausted, recurrent palatal fistulas, anterior palatal fistulas.
Okay, any other situations? Yes.
patients with comorbid conditions or syndromes who cannot be operated who are not fit for operation at the moment, sir.
Right. Okay. So we completed 4 questions for team 1. Now team 2 will have to answer. Dr. Umar will take over.
Sir, can you first complete your, are you satisfied with all the answers? If you need to speak about some answer which was not satisfactory to you, we can finish that here, no?
Umar sir.
Yes, sir. I was telling if you are not satisfied your answer, some of the answers.
I was thinking, shall we go to the answers towards the end, because some questions will be almost similar to other teams.
Okay, let's
Let's complete this quarter. Let's complete this quarter, and we'll go to the answers one by one.
Okay, right.
So Dr.
Once
Umar Farooq sir will be asking questions to Tanjavur Medical College students Lakshmi Narayana and Sarda Aital. Team 2.
Okay. Team 2, are you ready?
Yes, sir. Good afternoon, sir.
Good afternoon. So, having seen the case of this, right?
Yes, sir.
So, this is the case of post-palatoplasty fistula formation, right? Palatal fistula. So, tell me which anatomical regions are susceptible to fistula formation?
Junction of
Junction of hard palate and soft palate, and anterior to the incisive. Also the soft palate.
So, anything else? How will you classify these fistulae?
Pittsburgh glass.
What is that?
It is one type, 7 classification is divided into 7 types. Start from hot palate to uvula, uvula to hot palate.
Yes.
One is
What is this classification called?
this for this spotter of 5 type times. It's a junction of hot palate and soft palates.
Can you tell me the classification
Yes, sir.
you were about to say? What are the types? Good. You started.
Yes, sir. One is uvula. One is uvula, sir. 2 is soft palate. 3 is the junction of hard palate and soft palate. 4 is hard palate. 5 is incisive foramen. 6 is alveolus.
Good. So good. So why were you hesitating? You know the answer? Good. Now the question is, there must be some cause. You know that fistula don't occur in every case, right? There must be some primary causes which can lead to the development of a fistula, palatal fistula.
Yes, sir.
Can you enumerate those causes? What can be the deficiency? What can be the cause so that the fistula occurred?
The inappropriate closure of the muscles or tension, the closure must have been in tense closure. The reorientation of the musculature would have not been proper.
Anything else? Good. One, you told me tension. Second, you told me
um, Musculature, inappropriate orientation or repositioning of the musculature, sir.
I don't think anything else. Good, good.
The position of the primary fistula, the size.
There is no fistula. You
Yes, sir.
have operated a palate.
Yes, sir.
Now
Size of
there is
the
likely chance of
initial size
fistula
of the
formation.
fistula and the shape of the width of the fistulas.
No. You have to tell the cause of fistula. Why fistula occurred. Right?
Yes, sir. The type
That
of
is
the
sep-
repair, if the more any pushback or the type of the repair, it is more prone to ischemia, the repair would have been dehiscent, so it may cause palatal fistula.
Good answer. Let us complete later on. Now coming to what you were saying, Jeff. How does the type of cleft? You know the type of clefts? How do you classify cleft palate? How will the type of cleft impact the likelihood of the fistula formation?
Classification,
Uh,
cleft of the soft palate only, cleft of the soft and hard palate, cleft of unilateral complete, cleft of soft, hard and primary palate, bilateral complete, cleft of primary and secondary palate.
This is
Good.
view
What is this classification called?
view
VU
classification.
classification.
View classification. Now, how will the type of this cleft, maybe type 1, 2, affect the fistula formation? Has any bearing of this classification on the fistula formation?
Yes, sir. More anterior, it is more prone to form fistulas. And
Bilateral.
size and width of the fistula.
Good.
Cleft, sir.
So you can say you are right. You can say the more severe is the fistula, right? More upper grade. Yeah, you are right. Then there are the more chance of the
Yes, sir.
fistula
Fistula
formation.
formation.
So these are the causes of fistula, why the fistula occurred. Now, if I tell you, how can you prevent it? How will you prevent it? You take certain measures during your palatoplasty, during your operation to avoid fistula formation. How
First,
can it be avoided?
the first closure should be tension free.
Good.
And
How it
orientation,
can be tension free? How it can be tension free?
like we can put relaxing incisions on both sides.
This is one. And what can you else do so that they don't occur?
Layered two, that should be 2-layered closure in hard palate and a 3-layered closure in soft palates.
Yes. Good. Anything else?
Soft palate should be properly retropositioned, and the musculature should be properly realigned.
Anything else? I am not satisfied your causes of the fistula and to prevent is again the same. What is the cause? You have to remove that cause. That is the prevention, right? Rest you did well. Thank you. Let us come to the third spotter. The third team
No,
for the same spotter.
the team 3 from Nair Hospital, Mumbai, Dr. Richa Goyal and Dr. Hussain Edenwala.
Good
Dr.
afternoon, ma'am.
Vibhuti Naik sir will ask questions to them.
Yeah, I have some problem with my video, so my audio is clear.
Yes, sir.
Yes, sir. Yes, sir.
So,
Good afternoon.
good afternoon. So my first question is, based on the embryological classification, what type of palate this was before the fistula happened?
This was a complete cleft of the
So this most likely must be a complete cleft
hard and soft.
involving the hard and soft palate.
So based on the embryological classification, what do you say?
And so it would be a classification.
No, Kannan and Starks, that's based on the embryological classification. So what type of palate was this before the?
Yes, sir.
Anterior and posterior. Anterior and posterior to the incisive foramen. Anterior नहीं होगा ना सिर्फ posterior. It will be cleft of the structure posterior to the incisive foramen or anterior and posterior.
So it's cleft of the secondary palate, basically.
Yes,
Yes.
posterior to the incisive foramen.
Yes. So my next question is, please comment on the arch. Are you happy with the arch?
No, sir.
No, sir, the arch, we are not happy. We want the width of the arch to be a little more, and also the tooth on the right side are malaligned. So you'd like to align the teeth on that side.
So what is the most prominent deformity seen in the arch?
The the pre the molar is inclined lingually, and maybe that will cause a crossbite to the patient. Without assessing both the mandible and maxilla, I cannot comment on the occlusion, but she may have a crossbite.
Is there any arch collapse? Do you feel
Yes.
as a contracture of the arch?
Till the arch is collapsed, the transverse width of the arch is reduced, and it should be expanded mostly.
Okay. My third question is, this patient has definitely speech anomaly, and we are not sure about the quality of muscle repair. So there might be various components of speech anomaly in this patient. So what will be the most consistent anomaly in the speech of this patient?
So there will be hypernasality of the voice.
Yes. Okay.
And also
Yeah. That's the answer. Patient will have hypernasality because the palate repair, we don't know how the speech will be. But based on this, we know there will be hypernasality. So this palate fistula, can it be closed by local tissues?
No, sir.
There is paucity of local tissue,
inadequacy of tissues.
so we'll have to add some tissue to close this palatal fistula.
So paucity of local tissue both on the nasal side and on the oral side.
Yes,
Yes,
sir.
yes, sir.
So you think local tissue is not adequate to close this fistula?
No, it's
sir.
not adequate.
Okay. Okay, thank you.
Thanks.
Thank you, sir. So now the fourth team from NIMS Hyderabad, Dr. Banu Chandar and Ramya Krishna will answer the questions put by Dr. Salab Kumar, sir. I invite Dr. Salab Kumar, sir, to ask the questions to team 4. Hello. Dr. Salab, sir.
I think Salab sir got disconnected or something. Madam.
I'll call him.
Yeah.
Hello. Arre. Oh. In your phone also you can join, sir. You can ask questions in phone also. Okay, sir. Right. Salab sir, there is a problem with the laptop. He is trying to get connected. Shall I ask Dr. Bajaj sir? Would you like to ask a few questions, sir? He will join next round, sir. Actually, he got disconnected and trying to join again.
Right, beta. Can you tell me what is the problem in the arch in this patient? Why there is loss of incisors and other teeth?
Fourth team should answer the sir's questions.
There is the fourth stream is coming down there. And the first question to them is the fourth stream.
Yes, sir. Yes, sir. No, team from NIMS, Hyderabad.
Yes, from NIMS, Hyderabad. What is the position of arch in this patient? Why did the loss of teeth?
Vanuchandar, Ramya Krishna. Are you available?
Yes, sir.
Yeah,
The arch seems to be collapsed.
Shalab is there now. Shalab can ask the question.
yeah. Sorry, my first laptop suddenly went off. So
No problem.
we are still continuing with the first spotter.
Yes, sir. Yes, sir. Your
still.
turn now to ask questions to NIMS pages. Vanuchandar, Ramya Krishna. Please respond.
You have asked the first question or?
Sir asked what is the deformity in the arch?
Yeah, which question have you asked?
What is the deformity in the arch?
Okay.
Bajaj sir,
Okay,
ask one
okay.
question, sir.
Yeah. Okay.
Shall I ask the first question?
Yes, sir.
Okay.
Yes, sir. Yes, sir.
Okay. So team 4, all the best to you. Okay. I am audible now?
Yes, sir.
Yes, sir. Yes, sir.
Okay. So now the first question is that what are the speech problems in cases of palatal fistula?
In cases of palatal fistula, the speech abnormalities we see are hyper and hyponasalities, nasal air emissions, and any articulatory errors can also be seen, sir.
Okay. So how does this palatal fistula that affects the speech?
Because the speech formation starts from the glottis and in a pattern it moves towards the lips. There is a gap in the palate. It leads to the release of the air from the oral cavity into the nasal cavity at the abnormal movements. This will lead to the articulatory errors and the nasality, hypernasality which we see.
Articulatory error in respect to which words specifically can you?
Yes, sir. The letters like the sa, sha, and Z. These letters are generally spoken by the soft palate and they move towards the lips. If the fistula is in the posterior aspect, these letters will be pronounced as mismatched by the patient. If the palatal fistula is in the anterior aspect, the letters like P, T, B, and D, the patient will not be able to speak them properly. The labiodentals, which are the F, V, and L and R letters, there will be a problem if there is a fistula in the most anterior aspect.
So what can be the role of speech therapy in such cases?
In all cases, we advise to start the speech therapy and we'll see the progress of the patient with the speech therapy. And depending on that, we'll progress to the management if the speech therapy is enough or we need to go for a secondary surgical correction.
Now, what is the psychological impact that these fistula they exert on a young adult?
In a young adult, this will lead to a lot of stigmata on the child because he is not able to speak in a language which is understandable to his peers at his age. So there will be a lot of psychological impact on the child as well as the parents. Sir.
Can you elaborate more on what psychological effects? I mean,
Lack of
can you say something more about this? What are the effects on the children with such deformities? Are you able to?
Yes, yes, sir. We are able to hear you.
Are you getting my question?
Yes, sir.
Okay.
In the yes, sir.
There is no negative marking. Kindly boldly tell the answer. No negative marking. The question will not be passed on to next team also. Whatever you know, you tell.
The child will have the inferiority complex because of the not able to being the normal speech is not there, and he might also be exposed to bullying by his peers.
Yeah.
Social isolation.
The child will be socially isolated, and
Okay. Lastly, how important is the multidisciplinary approach?
it's very important. The multidisciplinary approach in this case is very important, sir. We'll have to include the speech pathologist for the speech therapy. The orthodontist will also be taking part in this for the alignment of the arches, and the plastic surgeon is included for the correction of the palatal fistula if surgical repair is needed. The department of radiodiagnosis will also be needed if we need the video fluoroscopy.
And just now we talked about the psychological impact on the, so
yes,
we require a
yes,
psychologist also.
psychologist. Yes, sir.
Okay. Thank you. Thank you very much.
Thank you, sir. I invite the judges of today's session to give their remarks and marks to the each team.
Lakshmi madam, shall I tell the answers for the first?
Yeah, please. Yeah. Are they satisfactory from the panelist side? Please put your answers, sir.
Yeah, for the questions which was given to the team 1, the first question was, what is your spot diagnosis? Team 1, are you available? So whenever you are asked about a diagnosis, you have to consider 4 components in every diagnosis. One is the anatomical component, the etiological component, the functional component, and the pathological component. 4 things are there in a diagnosis. When you say anatomy, you told that it is junction of hard palate and soft palate, but this is little more anterior. It is more in hard palate. So it will be a type 4 palatal fistula. What other anatomical component do you see? As I discussed later, there is a collapse in the arch of the maxilla, as well as loss of incisors. There was crowding of the teeth. All this will have a bearing on your future surgeries. What is the pathological component? You told it is a palatal fistula, correct? It is a post-operative. You can see the part of the scarring on the hard palatal tissues. There is evidence of scar on the palatal tissue on the midline. And then functional, since this is only a spotter, you cannot comment, but you should tell that this patient might be having nasal regurgitation or speech issues. Speech is less likely in anterior fistula, more likely in posterior fistulas. Then what symptoms are commonly associated? So this automatically takes you to the next question. What are the symptoms associated? So this child is a 21-year-old child, might be most likely presenting with nasal regurgitation of food and fluids. Speech might not be a very pertinent issue because already the child is 21 years old, and we see that the soft palate and hard palate, whatever is visible in the photograph, seem intact, but we cannot see that absolutely that speech issues will not be there. But more important are the feeding and regurgitation issue. Then how does the size and location influence the severity? You told us nicely. There are 2 components in this question. One is size and one is location. So as you told, smaller sizes will have less symptoms. The question was on the severity of symptoms. So smaller size will have less symptoms. Moderate size will have moderate symptoms. Large size will have very gross symptoms. Then location, anterior palatal fistulas are more associated with palatal fluid regurgitations or food regurgitation, and maybe nasal infections and all. Posterior palatal fistulas are more associated with speech abnormalities. So this is how the size and location influences the severity of symptom. then can we temporarily close the gap, and what are the situations where will you close? So we can obviously, as you correctly told, you can close the gap temporarily using an obturator. In what situations will you use obturator? Number one, if the patient refuses surgery, once the patient comes with big fistula, you will definitely offer him something big surgery, maybe a tongue flap or maybe a local stage surgery or this buccal mucosal flap, something like that will be offering him. And it might be related to multiple stages of surgery, expansion of the arch. So patient may refuse. So in such a situation, since it is anterior fistula, you can always give them the option of putting an obturator. And second is when patient has other comorbidities, when operation cannot be done, these are secondary situations. Third is if patient has agreed for surgery and they are preparing the patient for surgery, in such a situation, you will provide an obturator till the actual operation is carried out. Got it? So this is about my part. Umar sir, you would like to add on your set of questions? Anything?
Yes. As they have correctly answered the anatomical regions, they told the classification also very well. Now coming to the second question which was there, that are the causes, and with the causes they missed the how to prevent them. So they were both interrelated. So in the causes you told only the tension.
Yes.
If there is a tension in your repair,
Yes, sir.
this can be one of the cause and very important cause. So other causes can be there. For example, infection. If
Yes.
post-operative infection occurs, it is one of the common causes of the fistula formation. So there will be infection, tissue breakdown, and the fistula can occur. And there can be also the surgeon factors and the patient factors. Among the surgeon factors, there may be the technical errors may be there. There may be inadequate closure may be there. You have not well mobilized the flaps, right? Technical causes can be there.
Yes,
Yes,
sir.
sir.
So patient, there are some patient factors can be also patient nutrition status is not good. There may be some systemic conditions which may affect the healing.
Yes, sir.
And among them, the most important is the infection. So infection you missed. And how can you prevent it? You have to do the reverse, right? So to avoid the fistula, right, your surgical tension should not be there on the suture line. The flaps should be relaxed. If you have to mobilize them more, if you see technically, they should be very easily approximated. You have to prevent the post-operative infection, and you have to well build the patient. Patient should be optimized. If you want to avoid the nutritional status of the patient so that the healing is good, and your technique should be fine. There should be less trauma to your flaps, well mobilized, avoid infection, avoid tension.
Yes, sir.
These are the things rest you did well.
Okay, sir.
Yeah, coming to my part, my past question was in what type of palate that this fistula has developed. So they correctly answered it was a complete cleft of the secondary palate, because beyond that you can see the palatal scar. So the anterior palate and lip was not involved in this case. And what was the arch deformity? They said arch collapse. Basically, it's a transverse arch collapse because of the scarring and the fistulation there. So it has tried to heal by secondary intention, and maybe the fistula size was bigger and it has become smaller because of the contraction of the arches. The third question was what component of speech consistently happens, speech problem happens in this, because palate repair, soft palate, we don't know what was the quality of repair, muscle repair, what was the articulation issues. But one consistent problem here will be, because it's a large fistula, there will be air escape in the nose. Hypernasality is a must in this patient. The fourth question is because there is this fistula basically mostly looks like a surgical error, because there is a large fistula and the anterior, both the palatal tissues have necrosed. The nasal layer also has significantly necrosed, so large fistula. So local tissue is not adequate in this particular case to close the fistula. We require regional tissue like tongue flap or buccal flap to close this fistula. So these four questions they answered properly. Thank you.
So coming to my portion, the first question which I asked, what are the components of the speech which are affected in a case of cleft palate or palatal fistula? So they answered well. that these include the misarticulation, the hypernasality, there is nasal escape, and then one thing they miss that the proficiency of combining two words like S and T in stool and school. So that is also lacking in such cases. And when you have this fistula of such a large size, then definitely there is too much of nasal escape, so which will affect the speech. As far as the, we can't comment on the how the muscle has been repaired posteriorly. So that portion we can't comment, but it will, depending upon the muscle alignment, the speech will be further affected. Then my next question was that what are the psychological impacts on the such type of children? Definitely, these children, they have a peer pressure. They are not, the people are not understanding their language. So it is the peer pressure, the societal pressure, and even the family members, they are also under some psychological impact. And lastly, when I asked that what is the different components of the multidisciplinary team. So obviously the plastic surgeon is required to repair the palatal fistula. Then we require the speech therapist. Then we require a psychologist who can understand, who can analyze the problems in the child and then correct it. Then we require this orthodontist to correct the dental arches. And lastly, we will also require the help of our radio diagnostic colleagues for doing the test and for doing the X-rays. Thank you.
Now I invite the judges, moderators, Dr. Bhattacharya sir and Dr. Arun Kumar Chaudhary sir, to put some remarks and give the marks also. Bhattacharya sir.
Yes. First question, I expected some of the panelists would have asked that when the fistula should be repaired after the primary surgery. Because once it becomes evident, then the attendants keeps on asking, sir, why don't you close it early? So you have to tackle the attendants as well, the parents, and then you have to explain why and when
Sir,
the fistula
any
closure.
team would like to answer your question? We'll just ask them also, sir.
Okay.
Yeah.
Any team wants to answer?
Any team? Just answer sir's question. When you will address this type of fistulas?
You have observed a post-operative fistula after say 7 days.
Wait for
Now, when should you
Team 1,
operate?
would you like to answer? Team 2?
Ma'am,
Team
can
one.
get the question again, ma'am? Sorry.
If you see this fistula after in 7th post-op day,
Yes, ma'am.
what will you advise? When will you plan your fistula repair?
After 7 days, we'll have to wait for the infection. Most common cause would be infection for the gaping. And we will wait till the infection subsides, maintain good oral hygiene. Only after later the fistula will be repaired.
When?
Later means
Later
when?
means
At
when?
least after 3 to 6 months of.
Team
After?
2? 6 months, sir. After 6 months.
3 to 6 months.
After 3 to 6 months is your answer. Team 2?
After 1 year. Okay, 1 year.
What is the cause?
Cause due to maybe infection or inadequate closure.
Forget
Team
about the
3?
cause.
Okay.
You see a fistula after 7 days surgery. When would you like to operate and repair the fistula?
1 year they told, sir.
1 year. Okay.
Yes, sir. Team 3?
After 6 months, sir and ma'am, because you would want to see all the inflammatory changes, edema, everything to settle, and then you will only attempt surgical closure again. So 6 months.
You'd like to wait for. And in the
Team
meantime,
4?
we educate them about local hygiene and feeding methods
To optimize the
to
nutrition
optimize the
status.
nutrition of the child and maintain good oral hygiene, so that later, after we do the repair the second time, the results can be better.
So 6 months is your answer.
Yes, ma'am.
Okay. Team 4.
For at least 6 months to repair the secondary fistulas.
6 months.
Yes.
Yes, ma'am.
So Bhattacharya sir.
Now, why do you say 6 months or 1 year? What is on what guidelines you decide 6 months or 1 year?
After a surgery, the patient, the fistula, the periosteal flaps is elevated. There is a inflammation and there is friability of tissue. And secondly, there is.
Can you become louder?
If the fistula is smaller, can wait for some time so that the fistula.
No, same size of fistula. Because we are talking about this spotter.
Yes, ma'am.
So you please tell about this only.
Yes. For the local tissues too, we'll wait for the local tissue to settle down and we'll optimize the patient and we'll prepare for surgery after 6 months.
Bhattacharya sir.
Yeah.
3 teams told this is after
6 months and one team said
1
1
year.
year. I think as per our experience, we'll agree with 1 year because there is no hurry. Why there is no hurry? Because you want adequate mobility of the tissue, vascularity as well as mobility. And usually it takes at least a year. If you venture earlier, then again you may land up in another fistula, maybe smaller than it. But there is no harm in waiting. This is not an emergency. So you have to explain and tell the parents very nicely that we want this, and you have to draw it, you have to move your paper and show them that this is what we want to do. Now, so 1 year is acceptable. Second question should have been that what are the principles of fistula repair? Very straight. This fistula is there. As a surgeon, what is your principle?
Team 1.
To give a tension-free complete closure of the palate.
That's a vague answer.
Principles. Not prevention.
To provide a 2-layer
for fistula repair.
To provide a 2-layer closure of the palate, including the nasal and the palatal layer, and avoid the suture lines being in the same, overlapping of the suture lines of both nasal and the palatine layers in order to avoid refistula formation.
Absolutely. So it has to be 2-layered, one nasal layer, one palatal layer, and the 2 suture lines should not fall in the same plane. Why it is so? Why not in the same plane?
Chances of recurrence of the fistula and dehiscence are more common, sir.
Why?
If 1 layer dehiscence, the chances of it spreading, and the second layer dehiscing is also, if it's in the same line, then the chances are higher than when they're not along the same line.
You are correct, but why? Why same plane suture is more likely to open up? And how the 2 suture line, the different plane protects that?
If it's in the same line, if 1 layer has given way, then there will be
Another layer to protect.
Another layer which can provide a back of tissues that will not dehisce again.
Yes, see, the whole brunt will be on the say palatal layer. So if nasal layer opens up, the whole brunt will be on the palatal layer, and there is more likely to be that will also open up. And is there any difference in the post-operative feeding in primary palate repair and in fistula repair? Suppose you have repaired nicely a primary palate, and now you have repaired a palatal fistula. Will there be any difference in the feeding regime?
Team 2 answer.
Feeding should be started later, delayed compared to the first surgery.
How long?
2 days post repair.
Post?
48 hours post repair of the fistula.
How many days after repair you said?
2 days.
2 days. And during these 2 days, what will you do?
Fluids,
IV
IV fluids.
So why not 3 days IV fluid, 4 days IV fluid? That will give more protection.
Team 3.
Yes, ma'am, we would keep the patient NBM for a longer time, around at
How
least
long? How long?
1
sir?
week. 1 week, and we would start trials tube feeding, sir, for the child, ma'am, for maintaining the nutrition.
See, you must always classify feeding into 3 parts: liquid,
Sir,
semi-solid,
let
and solid.
team 4 and 1 also to answer.
Yes, yes.
Team 4.
Start the liquid diet. Patient is conscious. And we can
Loud,
continue
be loud. Be
start the
loud.
liquid diet. We can start the liquid diet immediately when the patient is conscious, and we have to continue it for 2 weeks, 2 to 3 weeks.
Be loud. You are not audible at all.
You're not audible.
Ma'am, are we audible, ma'am?
Yes.
Yeah, now audible.
We'll start with the Riles feeds for the initial, after the patient is conscious, we'll start with the Riles feeds up to 48 hours. After that, the liquid diet is given for 2 to 3 weeks. Later on, the soft diet is started.
First, you will put one Riles tube for 2 days.
Yes.
Then you will start liquid.
Team 1.
Ma'am, we can start liquid diet post-op day 0 to 1, but with good oral hygiene, asking the patient to with good oral maintaining or good oral hygiene and mouth wash regularly after consumption of liquids. Then we can start semi-solid as the patient tolerates in the first 2 to 3 weeks,
Liquid
and
diet.
then solid diet after 3 to 4 weeks.
This is team 1.
Yes, sir.
See, you have to continue the liquid diet as compared to the primary palate repair for a little longer time. That means, usually say we give liquid diet for 2 weeks. Here it may be prolonged for 3 to 4 weeks because the palate is not the original virgin palate. So let the repair become stronger. So at least 3 weeks you can give liquid diet. But the problem occurs that this is okay for a child, but what happens to an adult? Because his requirement is different. So even in adult, that is another problem whenever we operate an adult case or a teenagers, because they are habituated with the solid food or semi-solid. So to continue for liquid diet for 2 to 3 weeks, it becomes difficult. But for you have to explain them for the strengthening of the repair. You have to continue liquid diet and mouthwash after every diet, and it is to be filtered. Whatever liquid you are giving should be filtered, and then feed, and then mouthwash, because you cannot clean the oral cavity by your forceps, gauze piece, etc. So frequent mouthwash is important for every feed. So in such fistula, which is very difficult one, we should continue for 3 weeks and then semi-solid again for 3 weeks maybe. So we go slow as compared to primary. Okay.
Sir, according to you, how many marks for each team?
I think Dr. Arun will also.
Yes, sir, I'm noting down all the marks.
Yeah.
Sir.
Yes, yes.
Can I start?
Yes, sir.
Okay, team 1, Shushma and Smriti, you have performed very well. But in fact, always there is a space for improvement.
Yes.
So already Professor Bhattacharya has already elaborated many things. I am not going to repeat again. But again, some things in this particular case, what is the challenge during the operation in an adult case and palate?
So there could be extensive scarring because of the previous.
Oh, on table, please have patience to hear the question first. Then you, like, computer, you have to take little time. Don't be hurried. Okay. So what is the challenge on table?
There could be insufficient flap for closure.
Insufficient space for operating, sir, as the oral cavity, the mouth opening.
That is actually relative. What is absolute problem can happen, for which you have to be prepared in comparison to a child. Team 2 can answer. Hello?
Yes, sir.
Team 2 can answer.
Team 2.
Yes, sir.
What is the challenge on table? Team 3?
So we would expect decreased laxity and mobility of the tissue, sir, in an adult compared to a child.
Already he has told little. Team 4?
There is an increased risk of bleeding. There is a increased risk of bleeding in an adult case.
Yeah, absolutely. Suppose you have a bleeding, you are anticipating. What blood investigation will do for that before?
Complete blood picture and BGT.
No, specific. But there is no time. We want a very specific answer.
CTBT will do, sir.
CTBT and BGT.
No, nowadays CTBT is never done in any medical college for anesthesiology. They will not accept. Anything else?
PTINR.
Yeah, you should have told that. Anyway, I'm not going to repeat.
Yes.
Then team 1, I'm asking, what about in this patient, in adult patient, what could be the status of hearing? You have told about nasal ejection, nasality, phonation, food regurgitation, all this.
Yes.
Do you expect a normal hearing in this patient? Or a normal speech?
The speech will definitely be affected, sir. But because of frequent URTIs, there could be any ear tract infections, frequent ear tract infections as well. So,
Yes. So what you are seeing here is 2 dimension. So you have not seen the patient in a 3 dimension with allowed investigations. So your answer should be also that I have to investigate in 3 dimensions, all the investigations with imaging and all that. Okay. And other, like I told you, there must be a speech and also hearing loss. Okay.
Okay, sir.
But you have performed very well. You should be more confident in answering. And team 2, I am going to. You have told about the classification.
Yes, sir.
Yes, sir.
But why carrying the half? This is a type 4, isn't it?
Yes, sir.
Yes, sir.
But what about type 5, type 6, and type 7? You have not told even after repeated.
Sir,
Told by
type 5 is junction of primary and secondary palate. Type 6 is pre-alveolar and type 7 is post-alveolar.
Oh, okay. Lingual and
Lingual and
alveolar.
labial.
Yes. And type 6. You see, this is Pittsburgh's fistula classification. It cannot be changed by us, by you also. Okay. So what is 7?
Labial, sir.
Only labial or labial alveolar also.
Alveolar.
Labial alveolar, post-alveolar.
You see, the classification you have to anyway by heart it. Okay.
Yes.
So that was a point of I thought. And regarding the nutrition we have talked about, why the liquid food is given, not solid food
Sir,
to the palate repaired patients?
liquids, sir.
To prevent dehiscence of sutures, sir.
To any infection.
Next, team 3 or 4.
The solid food will it can get lodged in the fibers in the sutures which you have taken intraorally. So it will be difficult to difficult to maintain oral hygiene.
And it will also act as a source of infection, sir. So we prefer liquid feeds.
And
So what type of food you are giving in palate? What type of liquid food?
so we filter the liquids. If it's milk, then we make sure it's skimmed milk. Or if they're giving juices, then we strain the juice.
How to give that milk? How do you give that milk? Just you make a milk. Huh?
We strain and
do you filter it or not?
Yes, sir. We filter it.
These very small things, but it is very practical to the patients because most of our patients are not knows everything about it. Okay.
Yes, sir.
Then you talked about infection. Already it has been told by your panelist. But if you do not expect, if you expect an infection in palate operation repair, what pre-operatively test will do it?
Total leukocyte count.
No. Local. I'm
T4,
talking.
team 4.
We
Didn't
would
get
like
the
to do
question.
a throat
Team
swab,
4.
ma'am.
What for?
To look for streptococcus, ma'am.
What streptococcus? You should be very specific. It is what streptococcus?
What streptococcus? There are so many streptococcus, staphylococcus.
Pyogenes, Streptococcus pyogenes.
Team 1.
Pyogen is correct.
Team 1.
Pyogenes.
Team 2.
Viridians also, ma'am.
Beta
Team
hemolytic.
2.
Beta
Team
hemolytic streptococcus.
Who answered this? Team 2.
Who answered it? Team?
Team
sir.
2, sir.
Team 2. Very good.
Yes.
Okay, in all team 3, I'm asking you, you told about repair, okay? Already Professor Bhattacharya has told how to repair and answer been there. But always even you plan for any repair in plastic surgery, you should have in mind to planning in reverse. So you must have how to plan it. That is the principle. How to plan it and what flap. Should I take a musculobuccal flap or a tongue flap, whatever. That has to be done in planning in reverse. And when you speak of a reconstruction, it is similar also planning in reverse. So this PR has to be made in every way.
Yes.
So I think that thing you should have told when the reconstruction of the defect was asked for. Then team 4.
Yes, sure, sir. Thank you.
Team 4, I'm asking the plasticity of brain.
Yes, sir.
If it is done in the children, then that is there. So the speech is not affected because of the palatal velopharyngeal incompetence. It also happens due to the plasticity of brain which is there in the childhood. That's why it is done early.
Yes.
Okay. So that is one of the causes. So I think I'm not going to take more time. I am finished. I'm done. Madam.
Thank you, sir.
Thank
Abbas Mystery, sir. I invite
Hello.
Dr. Abbas Mystery, sir.
Yeah, madam, I'm there.
Sir.
Yeah. My one question to the entire, all the 4 teams, matlab, starting from number 1. Okay, suppose you had a complete cleft of unilateral anterior and posterior, and you had another patient with a posterior complete cleft without the anterior cleft. Which is more difficult to close?
Only with posterior. Only with the posterior.
Why? Which team is answering?
Sir, team 2.
Yes.
You said
Tell
posterior.
the
Okay,
Lisa.
next team. Team 3.
Yes, sir.
The one with complete
Anterior
cleft. Or...
complete will be more difficult to manage, sir. Complete cleft
Okay.
will be more difficult to manage than incomplete cleft.
Team 4.
Posterior wide clefts are difficult to manage. Posterior wide clefts are difficult to manage.
And team 1.
So posteriors would be difficult to manage because in repair of posterior, we would have to mobilize tissues from anterior palate. Also, relaxing incisions will have to be given later.
Yeah. So it is the posterior palate, cleft of the palate only is difficult to repair. And the fistulae are more common with this posterior cleft than with anterior. Of course, the anterior cleft, you have to close the anterior alveolus Now there are theories. Earlier we used to take Muir flap. Anybody can answer what is the Muir flap? M-U-I-R, Muir flap.
Team 1, Team 2, Team 3.
No.
Would you like to answer Team 3?
No.
No, ma'am.
Team 4. This flap is used to close the anterior fistula. Can you tell where it is taken from?
Alar base.
No.
Tongue, from the tongue.
No.
No.
Buccomucosal flap.
Nasal
Turnover flap from the palatal adjacent palatal mucosa.
No, it is taken from the lateral aspect of the mucosa of the lip and taken down when you close the anterior fistula, or when you are closing the lip, you try to close the anterior palate, some portion of it. So that later on, when you are closing the posterior palate, it is easier. But now the views are that when you use this oral lip mucosa, then the migration of the teeth is a problem. Tooth is a problem. So it is better to leave it, and when you are doing alveolar bone grafting, that time to close the anterior fistula, what remains. You close the lip, anterior lip, and then you close the posterior palate, and there is some defect always remaining, which is very difficult to close. So this you should know about it. I think, ma'am, that's all.
Okay, sir. I invite Dr. Mustafa Kadir. Give your remarks and marks, sir.
Remarks as of now, nothing.
Okay.
But one fundamental question was missed, and if you permit me, I'll ask them.
Sure, sure.
Any team can answer. So what are the tests you will do when you encounter a fistula like this? Because you have to ascertain nasal regurgitation, you have to ascertain speech. So what are the tests that you will do?
We will have to test for
Team 1.
Team one.
We will have to test for VPI as well, sir. So with an obturator in place, we can test for the VPI, the mirror test and fogging and everything.
Okay.
We have to test for VPI as such and nasoendoscopy.
Your answer is partly correct. With an obturator, you look for hypernasality. So what would you do further?
After that, we can do a mirror fog test, sir.
Why do you want to do a mirror fog?
Nasal air escape, to look for the nasal air escape.
Okay. Now you have put an obturator, and let us say the hypernasality still exists. So what would you do?
So the hypernasality would be because of VPI. So then we'll have to operate that also in the same sitting. So.
Good. So therefore, when you are assessing, you have to assess to know if the hypernasality is due to the fistula or if there is a pre-existing VPI. Besides that, team 3, any test you would do?
Team 2 over, sir.
Team 2 over. Team 3.
Team 2 not over.
No, not asked anything, sir. Team 1 answered.
Yeah. Okay, team 2. Fine.
Sir, I'll like to calculate nasalence.
Okay.
By air escape from the nose divided by air escape from both nose and
that the team 1 has already answered. So
fluoroscopy.
Besides, 1 minute. Let me make your life easier. Besides assessing speech, the tests for speech, what she already mentioned, anything else you would do?
Audiological assessment.
Pardon?
Audiological assessments.
Audiological assessment. Anything else? Simple thing.
From throat swabs.
No, you can do a water holding test, because it is not necessary that every fistula can cause regurgitation. Sometimes you will have fistula, but they will not. They will be asymptomatic and there won't be any regurgitation.
Okay.
Team 3, what are the two important things that you should assess whenever you see a fistula, especially in the anterior region or anywhere for that? What are the
Firstly,
two fundamental things you have to look for in your assessment?
size of the fistula and also
The location, the size of the fistula.
The size of the fistula and
the location and the severity of the symptoms.
okay, and the severity of the symptoms is not going to alter your treatment plan.
The surrounding
Plan the treatment
the
for you to
surrounding
plan.
local tissue, if they're adequate or not for
Exactly.
planning repair of the tissue.
So the size of the tissue and the quality of the local tissue available. So how would you assess the quality, especially in the anterior region?
Anteriorly, we have to, if it's a moderate size of fistula, we can plan for if the local tissue surrounding appears to be adequate.
Let me put forward my question again. I'm talking about the quality of the tissue. We have discussed about the size, the quality of the tissue. So how would you assess the quality of the tissue, especially for an anterior fistula? Let's say you have a 5 millimeter fistula, and then you have the surrounding mucosa. So how would you decide whether you would do the local or you use the local tissue in order to close? So for that, you need to assess the quality of the local tissue. So how would you do that?
So we can see the color and the texture of the mucosa. If it is a healthy pink color and
That's
smooth
all?
pink, and
Surrounding any other scars are there. I mean, in the midline there will be a scar, but if the look for scarring and color and
Anything?
mobility of the tissue.
Anything, a particular pointer or indicator that the tissues are viable? Team 4. You look for the palatal rugae. If there is presence of palatal rugae, it is an indication that the tissues are viable. Thank you. These are the only few questions that I would ask. And I have given the marks, but I would not like to announce it. I don't think so we should announce it here right now.
So let us move to the next round. Dr. Tahir, should we move to the next round?
Shall we start the next round, Lakshmi madam?
Yes.
Yeah, Dr. Abhilasha is available, madam. You please, Dr. Abhilasha is there? Okay, now we go to the next spotter.
We'll start with
This is the second spotter, starts with the team 2. Dr. Devi Prasad Mahapatra will start the session.
Okay, ma'am. Thank you, madam.
Yes.
So coming to our second spotter, team 2.
Yes,
So
sir.
we have on screen a 7-day-old child.
Yes,
Okay,
sir.
As you can see the diagnosis.
Yes,
So
sir.
now we'll start with the first question. If this child comes to you at 7 days, what are your essential components in your initial assessment? What are the things you will assess initially in this child for this particular baby?
Sir. First, I will assess the feeding of the baby and the width of the cleft and any palatal abnormalities are there, and audiological, any hearing abnormalities are there. I will advise feeding.
No, we are talking only about the assessment. What
Yes.
other things you will assess? A 7-day-old child, parents have come from their village to meet you in OPD. So
Yes,
what
sir.
other things you will assess? You told feeding, you evaluate feeding, you told audiology abnormalities.
Yes, sir.
Yes, sir.
Anything else you will assess?
Yes, sir. Any look for any palatal abnormalities or arch, about the arch, and investigations I would like to do.
No, only assessment.
Only assessment.
Only assessment clinically what you want to do and exclude.
Yes, sir.
What other assessment?
What other assessments are required for a cleft lip.
Okay. Shall we go to the next question?
Yes,
Yes,
sir.
sir.
Yes, sir.
So now this child is there. You told you will see for feeding abnormalities. So how will you evaluate feeding issues in this child?
Sir, I will look for any regurgitation or aspiration, and I will assess the feeding technique followed by mother, and I will like to advise on the proper positioning and usage of.
No, don't go into advice now. We are talking about evaluation only.
Yes, sir.
Yes, sir.
Okay, now this child, how will you evaluate the feeding issues for this child? First of all, you told you will take a ask the mother regarding
Yes, sir.
the history.
Yes, sir.
Then what
History.
happens? How will you evaluate? Tell me fully.
We look if there is proper latching of the lip over the nipple areolar complex, sir.
Sorry, tell again clearly.
Latching of the lip over the nipple, sir.
So under observation, you will observe the actual feeding
Yes, sir.
behavior of the child. Then
Yes.
what else?
And
History. Second is direct observation of the feeding behavior of the child, the movement of the lips.
Yes,
Yes,
sir.
sir.
And is any other thing you want to use to evaluate?
We'll see if there is any regurgitation.
Okay. Then
And nutritional status or dehydration status of the child.
Bluetooth असला कुठे? Bluetooth मध्ये तुझं headphone लावत होता ना? बघायचं? नाही.
hydration of the child. Okay. Then
Video हा? तुम्ही केलं video on कर.
Arun Kumar, sir. Kindly
Yes, ma'am.
mute your sir.
Hello.
Arun sir, can you mute it, please?
Mute your speaker, sir.
Okay.
Yeah.
So what you are telling, team 2?
Yes, sir. Hydration status and the output of the child, urinary output, like.
Okay. So can you repeat all the 4 things what you told?
Yes, sir. Proper seal of the lip to the nipple areolar complex, and I will look for any regurgitation or regurgitation while feeding, and I will observe the feeding technique and position of the mother, and hydration status I will like to assess, sir.
Okay. So we'll go to the next question. So what are the initial advice you will give to this parents of this child?
Yes, sir. First, I will counsel the parents about the defect and the surgeries required and any feeding techniques, and the before the surgery pre-surgical techniques I would like to counsel the parents. I would like to advice regarding the position of the feeding around about a 45 to 60 degree angle, and around with the long nipples feeding should be given, and I look for any regurgitation while feeding, and I would like to give a molding for pre-surgical nasal.
Talking about advice, what advice you will give? There are 4 or 5 advice specific things you have to tell to the parent.
We have to advise about the football positions.
Sorry?
We have to advise about the football position, how to hold the child while feeding, sir. And after feeding, we have to tell about burping the child.
Feeding advice you told, correct? Feeding advice you told. You
Yes,
told
and-
about the surgical advice. What other advice you will keep on giving to the parents?
After the feed, regularly burp the child, sir.
No, don't go into the detail of feeding advice.
Okay,
Other than that, what else you will give? You go told surgical advice. What surgery is required for this child? All these things you will tell.
Yes,
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 What about the feeding part?
Yes.
So we are not going into detail. Any other broad advice you will have to tell to these parents? What things they have to look into?
Look
It's a
for
7-day-old child, no?
Yes,
So
sir.
what other things you have to think in terms of a 7-day-old baby coming to you? What other advice you need to tell them?
Sir, to keep looking for adequate weight gain, to nutrition. Also, if there is any ear infection, to immediately bring the child for treatment.
Any recurrent respiratory tract infections to look for,
Yes.
to be cautious of the infection.
Correct. Any other points you want to add?
we have to rule out other congenital anomalies.
or
Sir. We have
anomalies.
to examine the patient head to toe, and any other syndromic anomalies we have to rule out, sir.
Okay. So coming to the fourth question.
Yes.
So what are the specific feeding and surgical advice you will give to the parents?
Specific feeding advice is proper position and usage of nipples, and after post feeding, adequate burping of the child, and surgical advice. I would like to counsel the patient.
Just a moment. Feeding advice. Anything else you want to add? Position and burping. Anything else?
Ensure the position of the lip is adequately sealed to the nipple.
Okay. Surgical advice.
Surgical advice. I would like to enumerate the parents about the surgeries required and the possible outcomes and any secondary complications about the surgeries and the timing of the surgeries. And if needed, a pre-surgical molding may be needed if.
Okay, we're talking about surgical advice specifically. Other things you can give it. Okay, that finishes my questioning. Now, Dr. Umar can take over.
Team 3.
Dr. Umar will be addressing to team 3.
Team 3.
Oh, team 3, yeah.
Yeah, good evening, sir.
So, team 3, what is the diagnosis in this patient?
So the patient is having a left-sided unilateral complete cleft, appears to be a complete cleft, sir, but we can't say just on this one image.
Complete cleft of the primary palate.
Yes.
Unilateral complete cleft of the primary palate.
So, seeing the child and the width of the cleft, right?
Yes. Yes, sir.
So, what is your protocol of involving the cleft team in this first week? Because baby is 7 days old.
Yes, sir. So we can 7 days old child, we have to protocol wise first we'll have to rule out any syndromic association, and we have to look for other congenital anomalies of the heart, of the renal system. So we get a 2D echo or a USG done, and clinically we look for presence of any pits, syndactyly, craniosynostosis, any vertebral anomalies, any anorectal anomalies. After we have ruled out any syndromic association, then you'd like to advise the child, you'd like to comment on the feeding and for weight gain, and you'd like to advise for nasoalveolar molding so that the it will help in the in shaping the nasal cartilages and will help to reduce the width of the cleft. Once we can do that, then once the child is about 3 months old and the weight.
Right. Now, you were telling about the NAM. How would you assess the need for nasoalveolar molding? A child is in front of you. How will you assess that you need nasoalveolar molding? It is based on what? You
Team
understood my
3.
question?
Team 3.
Hello?
You have lost the.
Team 3.
They are there.
They are there.
Team 3. Do you understand?
Richa.
That is the problem.
Is it okay?
Hello?
Edenwala.
Yes.
Hussein.
Yes, sir.
Yeah.
Ma'am, are we audible?
Yes, yes.
Sorry, ma'am, there was some problem. Internet.
Yeah, please.
Coming up in between.
Continue.
As actually, sorry for the interruption, but we will consider genetic screening and we'll look out for any syndromic associations and other congenital anomalies in the child.
No, for NAM.
Yeah, after
NAM. How would you assess the need for NAM?
So they will have usually the nasal cartilage will be there will be changes in the nasal cartilage. The alar cartilage will be buckled and it will be hyperplastic, and there will be an increase in the angle between the medial and the lateral alar with the flattening of the flattening of the nasofacial angle will be more obtuse. So hence, with the help of nasoalveolar molding, you want to lift the nasal cartilage and elevate the medial crura. So the shape of the nasal cartilage is shaped, it's molded better, and it will also help us to reduce the size of the cleft. We can use
When will
either
you
active
start
devices or passive devices. So this is started.
We can start from the 7th week of life itself, sir.
7 days.
7 days. Sorry, 7 days.
And it's
the first
only
week of life.
yeah.
And
We only do
Don't
it up to
describe
3 months
everything.
post.
There are criteria for advising
one by
NAM you
one,
tell.
one by
Don't
one?
describe
Be slow.
everything. There
Be
is no
slow.
time.
One by one.
Yes.
Only 3 in points you tell. Don't try to describe everything.
Don't
Yes,
jump.
sir.
Don't
Yes.
The
overlap. One by one.
criteria for NAM application.
It should
That
be
is
started
done.
early.
Now,
Only
Not
listen,
starting and
listen,
all.
listen.
What is the criteria? That means
That I
what
have done.
teachers will advise you to start NAM.
Now, when will you start NAM?
So one is wide cleft you told, isn't it?
yes.
What about others? You tell like
In case of
They have told, madam. Now I am
yeah, they
asking, when
described
will you
everything.
start?
Yeah.
When will you start?
we
When will
can
you
start
start NAM?
with the patient when for a 7-day-old child also, so we can start NAM and we can continue up to 3 months only, because till 3 months the maternal hormones are in the system and the molding of the
You are
cartilage.
answering for the other questions also. You answer the questions what sir asked. What is
Yes,
the
ma'am,
time
we
means
can
you
start.
tell the time. That's all.
we can start in the first week of life up to 3 months.
Yeah, good. Next.
Why so? Why
Come on,
so?
sir.
Why so?
Because during the first 3 months of life, there are increased maternal hormones that will and growth factors that will help in the molding of the tissues, and also there is increased hyaluronic acid levels as well.
Yes. 4 questions over, Umar sir.
Yes, yes. You can go to the next.
Yes, we'll move to the next team, team 4. Dr. Bubiti Naik, sir.
Yeah.
Please.
Hello. Hello.
Yeah, sir. You take over and questions to team of 4.
Team 4. Yeah. My
Team
question
4.
is.
Bhanu Chandra Ramya Krishna.
Yes, ma'am.
Yeah.
Yeah, my question is, what criteria this child must fulfill to be operated?
Millard's rule of 10 should be fulfilled, sir. That is 10 grams of HB, 10 weeks of age, and 10 pounds of weight, which is approximately 5 kgs, and with the WBC of less than 10,000. So if this is fulfilled, we'll consider the child for repairs.
Okay. If the parents refuse to take this child home, can you operate the child now when the child is 7-day old?
No, sir.
They don't want to take the child home. They want you to do the surgery. Can you do it or not? A 7-day old
The
child.
cleft is wide. We can wait for a alveolar molding, and later on we can operate, sir.
No. I'm saying, can you operate a cleft when the child is 7 days old?
You tell yes or
No,
no.
sir. No, sir. I can't.
Okay. My question number 3 is, which components of lip are you going to operate when you operate on this child?
Sir, we want to see the vermilon and the cupid's bow at the same level as the opposite non-cleft side, and the philtrum height has to be same as that of the non-cleft side.
That's the lip component. Is it the only lip component you are going to operate, or anything else you are going to operate?
Nasal floor also, sir.
Nostril floor. What else?
And also the nasal component also will operate, sir.
Yeah, that's nostril floor. So
Nasal floor and the alar cartilages on the cleft side alar cartilage, there is an obtuse angle.
Now, will you operate the anterior palate?
Yes, sir. I will operate anterior palate if there is a palatal defect. and nasal fluorosis.
So in this particular child, which technique will be more suited?
Millard's rotational advancement is more suitable.
Why?
Because there is a excess tissue in the lateral cleft side, sir. So we can advance it medially, and there is a upward rotation of the cleft medial segments.
So this is a male child or female child?
I don't know, sir.
So if this is a female child, which technique will be superior? Let me specify them.
If she's a female child, we can go for a Tennyson Randall repair, sir.
Why the sex made the difference between Millard's and Tennyson?
Sir, and Millard's repair, there is a crossover of the suture line from the filtral column, sir, into the medial side. So there is a unsightly scar in the postoperative period.
No, see, listen to my question. This is a female child. So I am making clear about the sex of this child. This is a female child. So you are proficient in both, all the techniques. So which technique you like to do here? Hello?
I'll do with Millard's repair. I'll go with
Millard's.
Yes. Or anatomical subunit repair, if possible.
Okay, my final question is an embryological questions. Why this is on the left side? Which side cleft is more common, left side or right side?
Left side cleft is more common.
So why it's more common on the left side?
I have no idea, sir.
Almost 60% clefts are on the left side. So why the left side preponderance is there? Any specific embryological reasons?
No idea, sir.
Don't know, sir.
Okay, so I have ended my 4 questions. So questions for the next team.
So the team 4 didn't answer only one question. So team 1, I invite Dr. Salab Kumar sir to address the team
my
1.
first question is to the team 1, that suppose this 7 days old child comes in the OPD. So what will you tell to the parents?
So firstly, we'll have to reassure the parents that this is a treatable problem, and this will be done in multiple stages, and parents will have to get the child in every follow-up. And initially, also the sequence of treatment will be told. Feeding advices will be given, like the propped up position, feeding in 45-degree, and frequent burping and
small
recurrent
and
small
frequent
feeds, and immunization to be done at a regular schedule, and weight to be charted.
Okay. Now, my second question is that what are the advantages of the Millard repair? Can you tell me the advantages of Millard repair?
It's a rotation advancement flap, sir.
No, I'm asking about the advantages.
So there's a more amount of tissue which will be available for repair. It allows for tension-free repair, and it is a cut-as-you-go technique. So a lot of tissue
You
not be
mean to
discarded.
say Tennyson is not a tension-free?
Tennyson gives
is
a
also
scar.
tension-free, sir. But we can use more tissue.
I can agree to that it is a cut as you go. Okay. So
Yes,
that
sir.
is the one advantage. But then cut as you go will come only with the experience, not for the beginners.
Yes, sir.
So any other advantage you
The
can tell me?
specific advantages you tell.
The excess tissue from the non-cleft side can be rotated and advanced into the cleft side, sir.
Then what is the advantage? I mean, what is the patient gaining out of this?
What is the main advantages you tell?
One, you said that cut as you go. I agree. Okay. So you can change in between. Okay. That I agree. Any other?
It's a better curvature of the Cupid's bow with the Millard's
Yeah, the scar is along the
filtral
column.
column.
Okay, then
It can be used for wider clefts also.
for wider clefts. Okay.
And
Or
nasal,
is it the
nasal correction is also done in addition to the lip repair.
okay? Now, can you tell me the advantages of the Tennyson over Millard?
So it's a geometrical repair.
So
So
it's
it
pure
can be done.
geometrical.
The learning curve is lesser when compared to Millard because it has a fixed landmark points.
Then anything else?
Because it's geometrical, the filtral height matching will be accurate.
Yeah, that I agree that it is a purely geometrical. So it is good for the beginners. I agree. But something more? Okay. Can you describe the typical nasal deformity in a patient of unilateral cleft CLP case?
So the columella will be shorter on the cleft side, with the base of the columella being deviated to the non-cleft side.
Okay.
The medial crest of the alar cartilage will be shorter on the cleft side, while the lateral crest will be longer and wide. And the alar cartilages will be displaced inferiorly and posteriorly.
And
the nasal tip will be displaced and
no. This just a minute.
Yes, sir.
You said the alar cartilages, they are displaced where?
Inferiorly and posteriorly.
And
the cleft side, sir. And on the non-cleft side, it will be
no, on the non-cleft side, it is normal. I am asking on the cleft side only. It is laterally, inferiorly,
and posteriorly.
posteriorly. So it is in 3 directions.
Yes, sir.
Okay.
And the dome of the cleft is more obtuse on the cleft side. The ala will be flattened on the cleft side when compared to the non-cleft side. And
Okay.
the nostril size are also bigger on the cleft side
when
compared to the non-cleft side. The nasal floor will be lower, or it could be absent if it's a complete cleft. And the septum of nasal septum, the caudal septum will be displaced to the non-cleft side.
So the best way to remember this, that you should start from one side. Either you start from medial side, first describe the columella, the tip, the dome, then come to the alar cartilage, then you come to the alar base. So
Yes,
it
sir.
should be from one side, either from the medial side or from the lateral side. Okay.
Yes.
Thank you.
Thank you, sir.
Now all tapes completed. I invite the judges to give their marks. Moderator Dr. B. V. Bhattacharya sir. I invite Bhattacharya sir.
Yes. In front of the parents, how do you describe the future protocol as the child grows? They might have come only for lip repair, but that's not enough. You have to tell them in detail as the child grows. So how will you explain that? This is to team 2?
Sir, it is open to all teams.
Open to all,
Only whoever come forward, they will answer.
Sir, actually, we'll have to reassure the parent that it will be a staged procedure. Initially, the lip will be corrected. 3 months later, the palate will be corrected, and palate repair is as important as lip repair because lip is mainly for aesthetic repair, but palate repair is mainly required for functional rehabilitation of the child. And later, the child will also require before the eruption of teeth, the child might require alveolar bone grafts also as one of the procedures, and there could be minimal deformities, secondary deformities of the cleft lip or the nose, which will be corrected at a later stage.
Okay.
And then Orthognathic surgery also will be done at a later stage, at 10 years, around 10 years at least.
Okay.
And we counsel them about speech therapy as
What-
well, which is required at a regular basis.
So it as the child grows, the requirement will vary, and you have to tell them approximately that at certain at this age, at this age, at this age, how do you proceed? And what about nasal correction, primary nasal correction? What is your idea about result of the primary nasal correction?
At the time of cleft lip paper, I will like to do primary correction of ALA or by suturing techniques. Sir.
Does that mean that these patients will never require another future surgery for nose?
No, sir. It will require, sir.
You tell that also, Lakshmi Narayana.
Yes, sir. Yes, sir. If
When will you do?
secondary surgery may be done at a preschool age, at a 6th or 7th year of age.
Then?
Preschool rhinoplasty.
Then?
Rhinoplasty should be done after the platform is augmented or any collapse is there.
Time you tell age.
18 years. 18 years.
Yes, that's specific.
Yes, sir.
Okay.
Which team is this?
Team 2.
Team 2, sir.
Three,
Team
sir.
2.
Not two.
Okay.
Team 2.
So,
Team 2.
so why the left alar is at a lower level than the right alar base?
So the maxilla is hypoplastic on
Team
the
3.
left side.
Team 3.
The maxilla is hypoplastic on the cleft side.
And because there is abnormal insertion of the orbicularis oris fibers also on the ala and the columella, so that is why the nasal elements are dispersed.
Displaced laterally and posteriorly and inferiorly.
Can you explain it embryologically? If you know how the lip palate grows, the origin, then you will be able to tell this.
Team 4.
There is a failure of fusion of medial nasal prominence with the maxillary prominence. So the maxillary prominence lies at the posterior level compared to the opposite sides.
So at what stage you would like to augment it? Do you need augmentation of the hypoplastic?
Yes, sir. It needs an augmentation. We'll augment after orthodontics correction has been done. Later we go for a alar base augmentation at the time of alveolar grafting mostly.
Okay, so what will be your preferred tissue to augment?
Coastal cartilage can be preferred.
So if you have to harvest the cartilage,
Yes,
will you harvest it from nasal septum or ear or costal cartilage at a later stage of augmentation, rhinoplasty, etc.?
For rhinoplasty, costal cartilage.
See, these patients will require rhinoplasty and also augmentation of the hypoplastic maxillary tuberosity. So, what should be your preferred source out of these three?
Coastal cartilage will be my source.
Why?
Because we need a lot of grafts for the rhinoplasty along with the augmentation of LR base.
Yes. So that will give you most adequate amount because you don't have to worry about the paucity of tissue. And the last question is, we have seen this lip.
Yes.
What are the criteria of lip repair?
Stephenson criteria. Stephenson criteria. Five criteria.
Tell me the criteria.
Sir,
The
accurate skin,
muzzle and the mucosa should be aligned properly, sir. Nostril floor should be repaired properly, symmetrically. The vermilion symmetry should be there, and vermilion tubercle should be exposed. There should be slight eversion of the lip, and the scar should be minimized and should be hidden properly, sir.
Scar should be such that the approximation should not interfere with the other requirements.
What else? One of the most important aspects, functional aspect is concerned.
Adequate muzzle repair.
Tell me.
Yes.
Preservation of cupid's bow and vermilion ridge.
You are all moving on the surface. That's the problem.
Yeah.
Adequate repair of
Muscle-
orbicularis oris.
Muscle repair should be adequate.
The muscle repair. If you don't do it, what happens?
The incisor show will be there with the shortened lip.
What is the deformity?
Visual deformity.
Visual deformity.
And how do you repair the muscle?
With the double breasting of the orbicularis oris.
Double breasting means you
Vertical mattress.
reset them and just double breast it.
No, the orbicularis oris is separated from all its abnormal insertions and brought into alignment near the vermilion, and the vertical mattress sutures with
Yes.
Okay. So there are different types of doing the muscle repair. Can
Yes.
you name one or two? On table, the technique which we use. You have dissected the muscle,
Yes, sir.
both
We'll take a
sides
suture.
adequately. Then
We'll take a initial suture at the superior most part.
yes. See, muscle repair, every bite will have an effect on the surface.
Yes.
Let me guide you. Okay, so it's very important where you are taking the bite, how much muscle you are taking, because the moment you tighten it, there is an effect on it, on the
Yes.
surface. So
We have
now
to,
tell me.
yes, we have to suture the muscle with some tension so that we have to maintain the relaxation for the skin closure, and also we have to take the center of the philtrum subdermal.
Your expression is not adequate that muscle will be repaired with some amount of tension. Why should there be tension?
So that the
It is
superficial skin will be of less tension, so the post-operative scar will be good.
any other team? This was who was talking? Team 1? Who was answering?
Team
4,
Team
sir.
4, sir.
Team 4. Okay.
Sir, will you
Okay.
give the marks for the team,
Yes.
sir?
Yes, yes. Okay.
Shall we go ahead at the end? You will give the marks or?
I think that will be better.
We have
Okay,
given.
sir. Only one question. One
Yeah.
question, because we are running short of time already. 1 hour 45 minutes over. Shall
Madam,
I
I will
proceed
take
with
one.
the? Yes, sir.
I will take only 1 minute, madam. 1
Okay,
minute.
sir. Okay.
I asked to all the teams who answers, he will get a little better mark. Do you understand what is anthropometry? Anthropometry.
Anthropometry, isn't it, sir?
Yeah.
Yes.
Anthropometry. ARTHROPOMETRY.
Yes, sir.
Yes, sir.
What is that? Who tells? Which team?
Please,
Tell the team
Please,
name.
Team 3, sir.
please, please.
Basically, involves using local landmarks and measurements to categorize the nature of the cleft, which can help us in planning the surgery also, and also the outcomes.
Okay, it is accurate assessment of long-term outcome in these cases, which is called the fourth dimension in the cleft lip repairs. Okay,
Yes.
team 3, you have answered it. Anyway, among the two methods, Millard and tension, which method is better and in which case?
The gold standard is said to be Millard's repair only, sir.
For wider.
One of the panelists asked in which this patient we are having a female, which method will be better?
rotation.
Only one method, not two methods. One method.
Tennyson Randall method.
Tennyson Randall is preferred.
No, it will be Millard.
Millard.
I think the Tennyson Randall is more in the males.
Yes.
So whatever the scars comes, it is hidden by the mustache. Okay?
Yes.
Okay. And time of operation, Professor Naik was asking to somebody in the team 4, I think. It's a 7 days baby. Can it be operated or not? If the parents agree all the parameters are okay, the anesthesiologist have given the clearance, should you operate or not?
No, sir.
Yes, you can operate.
Sir,
Any
we can
team, sorry. The EPS, why? How?
Sir,
Which team? Which team?
team 1, sir.
Yes, please.
We can operate because in children it is known to have better healing because the fetal growth factor is more and the scarring will be less in a neonate.
Yeah.
Secondly, with it is said that the bonding is also improved with a repaired cleft when compared with repaired cleft.
And additional to that, the psychology of the parents and their family and in-laws, isn't it?
Yes.
Okay. Yeah, why? Can you do it some much earlier than that also? 7 days before also, can it be operated?
Intrauterine repairs are also possible.
Okay. I think done. I am not going to ask anymore. Thanks. Madam, please take over.
If no questions, we'll move to the third round.
Hello, ma'am.
Yeah. Sir, Abbas
Yes.
sir, you would like to ask any question?
No questions. I would like to just make a comment. We have been talking about which is a superior method. See, skin incisions, irrespective, this is what I have observed, irrespective whether the skin incisions are of Millard or of Randolph-Tennyson or any modification, if you have mobilized the muscles well, the ultimate results are very good. There is no such thing. A mustache only will hide the scars of modified Tennyson. Even in females we have done, and I can show you n number of cases where the scar is almost invisible. As long as you don't take your vertical triangular flap beyond the normal filtral column. So, when the students are new, the biggest challenge for them is when they start their practice, what should they start with? So whoever is your boss and whoever is doing the thing well and whoever your seen it, learn to dissect the muscles well. Irrespective of skin incision, I think Dr. Bhattacharya, Dr. Chaudhary sir, even Dr. Bajaj sir will agree with. Skin incisions are not important. It is your muscle mobilization which is most important. That's all.
Thank you, sir. Now we'll move on to the spotter 3. I request the panelists and the teams also be brief. We are running short of time. So I request Dr. Bibhuti Naik sir to start the session. Team 3 from Nair Hospital,
Madam.
Dr. Richa Goyal and the Hussain Adenwala.
Evening,
So
ma'am.
this is the spotter.
I think Devi should start with the third
Dr.
team.
Bibhuti Naik.
I don't
Yeah.
Sir.
Hello.
Devi Mahapatra will start the questions. Sorry, sir.
Yeah. After Devi will start with the questions with the third team.
Devi, start the questions to team 3.
Yes, madam. Yes.
I'll start. Okay. Team 3 ready?
Yes, sir.
Just
Very
look at the-
brief and sharp answers. Don't describe unless the panelists ask you.
Yes, yes.
As Madam has told, the team members just answer specific to the question. Don't go to beyond the topic. Otherwise, the questions will keep on changing. You will get more and more difficult questions. So now you see at this image, this is a 2-year-old male child presenting with this condition. What is the diagnosis?
So this is a left-sided complete cleft of the primary and secondary palate, sir. Unilateral. In a 2-year-old male child.
Anything else? Any classification? Anything?
This would be a O3 or a Nagpur group 3 classification.
Now we'll go to the next question. How this child is presented at 2 years. So it is an early presentation or a late presentation?
It's a late presentation, sir.
Late presentation. So how does this delayed presentation affect your surgical plan?
Sir, because the child has come at 2 years, so we would aim to first repair the palate, sir, because that would affect the speech function of the child, which was more takes precedence over the aesthetic repair of the lip. So I would counsel them regarding the need for palatal repair first, followed by lip.
And also further surgical plans will have to be explained to them. What are the other surgeries required as the child grows up?
Right. So our speech consultations take priority and you have to keep that in mind. Okay. Now, what are the surgical techniques available for palate repair you will consider for this particular condition? What surgical options will you consider?
Yes, so there are multiple approaches that are there. We can go for a von Langenbach's palatoplasty or
For this particular condition you're
this
asking.
particular sir, a Bardak's palatoplasty.
Any other condition? Okay,
or
Bardak is any other?
VWK palatoplasty.
VWK palatoplasty.
Okay, not done nowadays. Any other thing you will consider? Any other type of palatoplasty?
Or Furlow's double opposing Z plasty, sir.
Correct. Furlow's double opposing plastic. So now final question for you. What all muscles need to be repaired in this particular patient?
Yes, sir. So we would mainly we have to recreate the levator sling, sir. We would recreate the levator sling, sir, for this patient. So the levator veli palatini, the tensor veli palatini, palatoclastis, and the palatopharyngeus, sir, will have to be repaired.
And when you're doing the
Palatoclastis and palatopharyngeus, how will you repair that?
Sorry, sir.
How will you repair palatoclastis and palatopharyngeus? Tensor palate, levator palate, you told correct. What other muscles you need to repair?
And the musculus uvulae also, sir.
Musculus uvulae. Additional bonus point if you tell one more muscle which needs to be repaired in this child.
Auricularis.
Very good. My questions are over, madam. Over to the next panelist.
Okay, sir. Dr. Umar Farooq Baba. You ask your questions to
Team 4.
Team 4. Team 4 names pages.
Yes, ma'am.
Dr. Umar. I invite Dr. Umar to ask the next questions to Team 4.
Are you ready?
Yes, sir.
Yes, sir.
Now
Yeah,
patient
they
is
are ready.
presented to you as a late presentation. How will
Yes.
you proceed?
As a patient is presenting at 2 years of age, we can go with the hole-in-one repair, sir. Both at the same time, palatal repair along with the cleft lip repair.
What will be the advantage of this?
In hole-in-one repair, there is a in Indian criteria, there is a risk of there is a chances the patient will not follow up. So in hole-in-one repair, we are repairing lip and palate at the same time. So the follow-up may not be required.
What is primary gingioperiostoplasty?
Sir, I can't hear you.
What is primary GPP?
GPP, gingioperiostoplasty, is the boneless bone grafting. In this, the gingua is just sutured, mucosa of the gingua is sutured so that the cleft gap is reduced in alveolus.
Yes. Along with the periosteum, we'll suture boneless.
You are talking about hole-in-one repair, right?
Yes, sir.
Yes, sir.
Can you tell me what is Oslo protocol?
Sir, can't hear you. Sir.
What Oslo protocol? Am I audible?
Yes, sir.
What is Oslo protocol of
Oslo.
cleft repair?
We'll initially repair the soft palate along with the lip.
Yes. You talked about the primary gingioperiostoplasty. What is secondary? Am I audible?
Yes, sir.
Am I audible?
Yes, sir.
Yes, sir.
What is secondary GPP?
No idea. Sir.
Are over. Let us go to now Dr. Vibhuti Nayak, sir. He will be asking. to team 1.
Hello, am I audible?
Team
Yes, sir. Yes, sir.
Yeah, my first
one.
one.
Doctor, I invite Dr. Vibhuti to address. Yes, sir.
Yeah, my first question.
Smriti.
Yes, sir.
Hello, am I audible?
Yes,
Yes,
sir.
sir.
Yes, sir.
Yes, sir.
Yeah.
Yes, sir.
You are audible,
Yeah, my
sir.
first question
You
is,
are audible.
so if you have the option to operate with naked eye, loop, microscope, which one will you prefer for doing this palaroplasty?
Ideally, the microscope repair provides a better muscle dissection as it is done by Somerland, but I would prefer a loop dissection because I'm much used to it.
Which one is better? Loop and microscope, which one is better?
The microscope repair, sir.
My next question is, what is the most important step in palate repair to get good speech?
To get, sorry, sir.
So what is the most important step for palate repair to get good speech?
The posterior palate, the soft palate repair will influence the speech, sir. So the good posterior repair
With
and
muscle sling
Step,
formation.
that step called one step that describes a good palate repair.
So the muscle sling reconstruction has to be done. The
tension.
So what is the terminology called? Intravelar veloplasty.
intravelar veloplasty.
Should you keep blood cross-matched in all cleft palate surgery?
Yes, sir.
Routine cross-matching of blood.
Yes, sir. Preferably it has to be done in all patients because the risk of bleeding is higher, always higher in a palate surgery.
So what is the incidence of blood transfusion in cleft palate patients? So even though bleeding might occur, the chances, if in a skilled hand, the cleft palate normally doesn't require any blood transfusion. But you have to keep blood cross-matched. You never know which patient is going to give you a problem.
Yes.
Okay, that completes my 4 questions.
Yes.
Which
Thank
team
you.
was answering?
Team 1
Team
finish. Team 1 finished.
2 will now come. Team 2 will come now.
I invite Dr. Salab Kumar sir to
Yeah.
ask
Yeah.
questions to team
So
2.
yeah. So my question to team 2.
Yes, sir.
Yes, sir.
What are the arches problem in this patient?
So collapsed maxillary arch is present, sir.
Which side?
Left side.
Cleft side. And what about the non-cleft side?
We have to see it for the eruption of teeth, sir.
No. I mean, the
Yes, sir.
left side you said is collapsed.
Yes, sir.
Okay.
Yes, sir.
What has happened to the right side, the non-cleft side?
Couldn't make out from the pictures.
What is happening to the non-cleft side? Is it normal or is it collapsed or something else?
It is hypoplastic.
Non-cleft.
Yes, sir.
What about the movement? Hello?
Yes,
Yes,
sir.
sir.
Yeah. Is it somewhere? What has happened to the non-cleft side?
Displaced.
Is it rotated outwards?
Yes, sir. Displaced outwards.
Yeah. Why? Where are the orbicularis muscle attached on the non-cleft side?
To the midline, sir.
To the
So what will happen if they contract, if they pull?
So it will be contracted to the non-cleft side, sir.
So that is why it is moving outside.
Yes, sir.
Okay, now coming to the palatal muscles, where are these muscles attached abnormally?
Release of limits.
Hello?
Yes, sir.
You should answer fast.
Yes, sir.
You said the muscles, where are they normally attached, palatal muscles?
To the palatal shelf, sir.
Where is that?
On the
To the palatal shelf or in the midline?
Any bony part.
Pterygoid ham.
Where is this levator palati attached of the two sides? You said, na, the intravelar veloplasty is required.
Yes, sir.
So where are they normally attached?
To the palatine aponeurosis and the pterygoid hamulus, sir.
So it is in the midline.
Yes, sir.
So what happens in a cleft palate patient? Where are the abnormal attachment of the muscles, which you require them to be united in the midline?
You have to detach during the repair. How they are oriented in a cleft palate.
You know or you don't know? Say yes or no.
No, sir.
No, sir.
Okay. So they are attached to the posterior border of this hard palate and along the cleft margin.
Okay.
These are the abnormal attachments.
Yes, sir.
Okay. What is ABG?
Alveolar bone grafting.
So what is the timing? When should it be done? And why it is required?
7 to 9 years of age, sir.
Why?
Before eruption of canine
Canine.
tooth, sir.
Okay. Thank you. Over to you, madam.
Sir, 3 spotters, the total round is over. Now it is open for the judges. Anyone wants to ask the question or give the marks? You are invited.
Which team is answering?
Dr. Bhattacharya, sir.
Which team is answering?
Sir, whatever question you
Okay.
ask. No,
So
sir. It is not specific for
will you repair the palate and the lip in this case together?
third round, third team.
Will you repair the lip and palate together in this case?
Sir, it can be attempted, sir.
No, not can
Team
be.
4,
Will you be or not?
already this question asked.
Yes.
Yes, sir. We can repair both at the same time, sir.
Okay. So on the table, will you
Yes, sir.
repair the palate first or lip first?
I will repair palate first, sir.
Why?
For the visibility, we'll repair the palate and then we'll come for the lips.
Any other reason?
Intraoral repair will be visible when we repair the.
Okay. Any other reason? More important reason. Lip first or palate first?
Anterior palate repair. To do the anterior palate repair, it is better if we do later after the posterior palate repairs.
Why? We are doing all repair together.
Yes, sir.
Lip as well as palate, you said so. I'm just simply asking you why lip repair first or palate repair first, whatever is your choice. Defend that.
We'll see up to what extent the nasal flap will be closed to the anterior side.
Patient is in front of you, this particular case.
Yes.
No theory. In
At
this
what
case,
extent-
what
yes.
will you do?
At what extent we can use Vomer flap will be decided. And once we repair the.
Any other team?
Sir, Dingman cannot be put once the lip is repaired. So visibility of the palate is not there. If we do the lip repair first.
So is it the answer that once you repair the lip and therefore the Dingman cannot be played, patient is under GA, you can always do it, whatever you want to do. Any better reason for this? Any other team?
Lip blood trickling down.
Lip first or palate first? First tell that.
Palate. Palate first.
Why?
Visibility and
Visibility is not a problem. You are putting an app. No.
Width of the cleft will be reduced after the palate.
Another team is there, no?
Sir,
Yes,
if
sir.
there is a remaining cleft in the alveolus, we can, with the lip repair, it can also be corrected at that time.
See, you are going on technical part more of. Okay. Should I answer?
Yes.
Sir, if by any reason lip repair cannot be done, patient will again come back for the lip repair, sir, if palate is done first.
No. In this case, I am telling you that's another philosophy.
Okay.
In this case, we want to do lip and palate together. We have agreed to that. I am
Okay, sir.
asking whether lip first or palate first in your procedure.
On table,
On table.
palate,
Very practical thing.
will you do palate and then followed by that lip, or lip followed by palate?
Bleeding.
No.
Sir, you please answer, sir.
So the palate first, because you have full exposure, as you have said. You can repair up to the anterior alveolus, but that is not the main reason. Main reason is if you do the lip repair first, how are you going to put the mouth gag? You know, you are going to stretch it as you are opening, and it's likely that your mouth gag will damage the repaired lip which you have already done it. So there are two
team one
reasons.
answered, sir.
Yes. So there are two reasons. One is that you have better exposure from posterior to anterior up to anterior palate, and you can repair up to the anterior palatal fistula. You don't leave behind anything. And second part is that the thing, whatever mouth gag you are using, that might damage the repaired lip because your concentration is on palate, and that pressure will be on for at least 1 hour to 1.5 hours on that repaired lip. So therefore, palate first and lip next. That's it.
Can I have two questions only? 1 minute. Madam,
Yes, sir.
what is hole-in-one? And who is the plastic surgeon in India who has told? Or he
Charles Pinto.
Huh?
Charles Pinto.
Dr. Pinto and Dr. Golenia.
And who does this operation very frequently in South? And he has nomenclature and a lot of presentation. Do you have any idea? Dr. Mukunda Reddy. From Dr. Mukunda Reddy. Another same type questions. You do posterior to anterior repair of the cleft palate. But one surgeon from South who does from anterior to posterior. I am talking of cleft palate. You don't know, Dr. Samsi Bose. How to really assess what are the tests or assessments you can do for a velopharyngeal incompetence?
Yes, sir. Nasal endoscopy.
Yes.
Mirror test.
Which team you're talking about?
Team 2, sir.
Yeah, very good. Then go ahead.
Nasal lens, fluoroscopy.
Yeah.
MRI.
MRI.
No.
Nasal lens.
Anyway, nasometry, then speech aerodynamics, video fluoroscopy, and nasopharyngoscopy. These are all tests being done to confirm your velopharyngeal incompetence repair has been properly done, and with clinical assessment as well. Thank you very much, ma'am.
Any other judges would like to ask any questions? Abbas Mishri,
No,
sir.
madam, no.
Mustafa Kader.
Madam, can I just add one thing?
Yes, sir. Any panelists who want to clear any unanswered
I just
questions?
want to add one thing, that in a case of this group 3 CLP, the anterior palate should be done with the lip. That is mandatory. And if we are not repairing, then it becomes very difficult for the anterior palate to be repaired. And what we normally see in these cases, the patients coming with the anterior fistula, they are basically the residual defects, because the anterior palate has not been repaired in the initial time. That's all I just wanted to add.
Dr. Devi, sir, Dr. Umar, anything you want to answer related to
First, I just
One
want
more,
Third
can I say
spotter.
something?
Third spotter.
Madam, one more, I can say something?
Yeah, please.
Normally, the examiners, they do ask it in the exam that which repair will you do? Okay, so that is a very normal question which is asked. I think the best answer is whosoever procedure you are familiar with, whatever you have seen, you should answer that. Even if you say that I will do Tennyson or Millard, anything, you say that I have seen this repair being done at my institute. I am more familiar with this, so I'm more comfortable with this, so I will do this. And these are the advantages of this repair.
I think add to sir, Saleh sir, Millards and Tennyson both were there in 87 International Conference at
Yeah.
Delhi. So Tennyson was asked, which method is better, Tennyson or Millards? Then Millard answered, Millard method is best with Millard sand, Tennyson is best with Tennyson sand. What rightly you have told.
Yes. So if anyone is comfortable with any procedure, they can say that.
Dr. Matangi Ramakrishna only do cleft lip repair by Millard's method. And Dr. Venkata Swami does only Tennyson's.
Yeah.
So it will depend on the place where you have been trained.
Yes. So they can answer anything, but then they have to support it.
Yeah, that's it.
Because of the paucity of time, let us move to the next spotter. We have already crossed the time. Go to the next spotter. Hello, ma'am, you are not audible.
Madam,
You are not audible. We should go to the next spotter now.
ये तो हाथ नोटी लगा भी तुम्हारी बच्चों में
काम बदू
तने
खोले
बिल्ला भी किलो के नाप
Somebody, this is on. Please mute your microphones. Abbasar, can you mute yourself? Yes, sir. So why has this PP this gone? Screen is not being shared.
I think
Something has
Madam
happened.
got disconnected.
Yeah.
While she is connecting, I'll just recap the last spotter some questions and answers just to spend the time. Is it okay, Dr. Umar Farooq?
Please go ahead, but be in little bit brief.
Till Madam joins. Okay, so I had asked question to I think team 3, that last spotter. So one question I had asked, what technique will do for that particular case which we showed on the screen?
Yes.
So the preferable technique nowadays is Bardak palatoplasty with or without Furlow's palatoplasty. Furlow's is done for the soft palate. Bardak will be done for the hard palate.
Yes,
The advantage of Bardak is you can go for a alveolar extension palatoplasty. That means you take part of the alveolus and use it to cover the alveolar gap, which
Yes,
cannot be done in any other technique. If you can try one lungeon back, but it won't come. You can try Bardak, but you are leaving a lot of tissue in the anterior part. So the preferred method is Bardak. You can try the VWK. VWK leaves a lot of tissue in the anterior part. So the preferred method is Bardak palatoplasty because it has the possibility of borrowing alveolar tissues also to cover the gap. And if you are going for a hole in one repair, you can actually cover the residual gap while doing the lip repair. So that is the thing I wanted from the participants. And I think that's all from my side.
Regarding the Oslo, it is a staged protocol, Oslo protocol. It is simple, just you, when the child presents you at the neonate, you do the alveolar molding, nasal alveolar molding, followed by the lip repair, then you do the palatal repair, right? Only difference is that you do the palatal repair of the soft palate at 6 months, then the full-fledged repair, that is the formal repair at the 9 to 12 months. So let us go to the next spotter now.
So for
Then
the
team 4 will start with Dr. Devi.
yes, sir. So we'll rapidly again, team 4, be very specific in your answers. Don't
Yes,
jump
sir.
to other areas of the question.
Yes, sir.
Okay. Otherwise, the question keeps on changing and we'll have to ask more difficult questions. So now look in front of your screen. You see a patient with a defect. Can
Yes.
you give the diagnosis? What is the spot diagnosis for this child?
It is a complete bilateral cleft lip and palate, sir. Defect. Group 3 cleft of Balakrishnan classification.
Okay. And what other deformities can you see along with the lip
Along
deformity?
with that, there is a nasal deformities. There is a short columella with a bilateral alar flaying, and there is a widened alar base on both sides. And the prolabium is adequate, sir.
Okay. So now next question is, if you're planning to operate this child, what are the other pathologies which will influence your timing of surgery? What other things will influence the timing of surgery in this child?
The general nutrition of the child, weight of the child.
Hemoglobin status.
Yes. Then all the things you tell, this patient has come to you in OPD, you are planning for surgery. What
Yes.
all things will influence your timing of surgery?
We'll examine for any other congenital anomalies in the child. And for this particular surgery, we'll check for the hemoglobin, WBC count, and the bleeding time, clotting time.
Protraction of maxilla, premaxilla protraction is also factors.
Any other thing, any other associations? Will you look for any other syndromic associations in this kind of children?
We'll look for any syndromes like Vanderwood syndrome or velocardiofacial syndrome presence.
Anything, any deeper syndromes. So you need to take opinion of the other departments, pediatrician or a cardiologist.
Cardiologist for the 2D echo, sir, to look for any cardiac anomalies.
Okay, all right. Now you tell me, what is the approach to correct the nasal deformity for this child? And I'm talking about a broad approach. And with respect to the timing, when will you do approach that for
Sir,
correction of nasal deformity?
Yes, sir. Generally, we can operate a bilateral cleft lip at after 4 months of age.
The nasal correction is also done along with the lip correction, sir. Can be done at 3 to 6 months of age.
And there is a wide prolabium. We can use the bilateral fourth flap for banking of the flaps for later columnar lengthening at a later dates.
So one is surgical approach, you told at the time of lip. Before surgical approach, any other approach you can do? Before surgical approach, before operating, any other things can be done to improve the nasal and premaxillary deformity?
Nasoalveolar molding can be done, sir.
With the
We
present
operate nasal molding.
And Latham device application can also be done, sir.
Right. Then post surgery, what other points of intervention you will do for nasal repair? What are the different ages where you will intervene?
we have to repair the columnar height, sir. We have to improve the columnar height.
This is, you are telling during the surgery, you will repair the nose. Got it. After this surgery is over, in later stages, when will you do the next nasal repairs, nasal related repairs?
At the time of starting the school, secondary nasal correction can be done at 4 to 5 years of age, sir.
And further?
And further, after the puberty has been attained at the age of 14 to 16 years, the final correction for the nose can be taken up.
17 to 18, we can do the secondary rhinoplasty.
Okay. So how will you do? What is your approach in this child? This is a 9-month-old female child. What is the surgical approach for this child?
Modified Millikan repair. We'll go with the modified Millikan repair in the initial stage, sir.
So if there
Along
is
with the palate repair. Along with the palate repair, sir.
First what we will do, lip or palate?
We'll do palate, sir.
How will you justify it?
The child has attained the age of 9 months, so we can go ahead for the palate repair as the parents are likely to bring the child back for the lip repair after in the follow-up, sir.
So are there any contraindication for lip repair, doing lip repair first at this age?
No, sir.
Then, so who will decide, like, you have the capability to operate both the lip and palate. Then who will decide which one you can repair first? Do you need to talk with somebody? Do you need to talk with
Orthodontist.
somebody before operating?
Orthodontist mentor.
You talk with the parents of the child, na? You
Yes,
ask them the opinion. That
Yes.
these are the things available. Okay. This finishes my questioning. Next to Dr. Umar.
Yes. Now team 1 will come, right?
Yes, sir.
Yes. Though the patient is in front of you,
Yes, sir.
what can you see in the middle of the picture?
The
Intubated tube, endotracheal.
Just below in the center, what is between the two ends of the lips?
the prolabium.
Prolabium. What is prolabium? Which part is prolabium?
In between the cleft,
Two clefts.
clefts.
Between the clefts. And what can you see just below the prolabium? What is that white?
What is
Teeth, the dentition, sir. Teeth.
Dentition. They are attached to what?
The alveolar and the premaxilla, sir.
premaxillary bone attached?
Premaxilla. Now, what is the blood supply of premaxilla?
So it arises from the septum, the vomerine area.
What is the blood supply? What is the blood supply of premaxilla? Got a point?
Anterior nasal.
Yes.
What is the blood supply?
Anterior nasal. Not sure.
Okay. Now, what is the composition of prolabium?
So it has a, it's a mucocutaneous part, and it is devoid of the muscle. It mainly has the mucosa as well as the skin covering with the premaxilla in it.
If you get a child who has the protruding premaxilla, what will you do? How can you manage it?
So initially, if the child is brought before 3 months of age at birth or any time before 3 months of age, we can use nasoalveolar molding procedures in order to reduce the protrusion of the premaxilla. Later,
Not the late presentation. It's a late presentation. There is protruding premaxilla.
the definitive in the definitive cleft repair also we can manage address this situation.
Now, why will this premaxilla grow ahead?
So because of the
Why it is
uncontrolled,
protruded?
normally the premaxilla has to fuse with the lateral maxillary processes to form a continuous arch, and the growth will be restricted. But here there is an unrestrained growth of the premaxilla because it does not fuse with the lateral maxillary processes.
And good
and hyperactivity of the suture, Vomerines premaxillary suture.
it is protruding ahead now. One is that it is not attached. Second thing, something is missing.
Absence of muscle, sir.
Restraint is lost. Right? Good.
Soft tissue restraint.
What are you know of any repair which is usually done for the bilateral cleft lip? Can you name?
Mulliken's repairs, Mulliken's kiloplasty.
Then that is already
Over,
told.
sir.
Ahead. One team had answered one. What are? Can you name any other repair? Other than
Modified
Mulliken?
Black's technique, sir, for bilateral cleft.
Yes.
Scoop method is there, Manchester technique. Wine's method and Millard repair is also there, sir.
Okay. Thank you. Let us go to now Dr. Bibhuti. Sir will be tasking to team 2.
Yes, sir.
Hello.
Vinayak, sir.
Yeah. So my first question is, this child is absolutely fit from all angles for surgery.
Okay. Yes, sir.
Do lip and palate together, or you will do one after the other?
Can do lip and hard palate at first stage, sir, and soft palate after 6 months.
Can you do everything in one go? If everything is fine with a patient is fit, absolute hemoglobin normal, weight normal. So can you do both together?
Yes, sir, we can do, but
Okay. Will you do anterior palate with the lip?
yes, sir. Follow Oslo protocol. That is
So when you are doing the anterior palate,
yes, sir.
In a bilateral cleft, what precaution you have to take to prevent necrosis of the premaxilla?
Sir, I will use the Vomerin flaps, sir, for head palate.
No, using the Vomerin flap can be problematic. So what precaution will you take so that the blood supply is conserved to the premaxilla?
No idea.
Okay, my third question is, this prolabium is formed because of what?
The skin and mucous membrane.
Cutaneous tissue
Or
from
which embryological component?
medial nasal processor.
How many?
So two fused medial nasal processor.
Okay, fine. What is the blood supply to the prolabium?
Sir, from anterior ethmoidal artery.
Sure.
No, no, sir.
That was my fourth question.
Okay.
Go to the next team.
Yeah, can I start?
Yes, sir.
Yes, sir.
Okay. So how does this Millard repair differs in a bilateral cleft lip and a unilateral cleft lip?
Team 3. Huh? Sharad sir is asking team 3.
Yes, sir.
Yeah.
Yes.
So is my question clear?
Yes, sir.
That this Millard repair you do in a unilateral cleft also, you do in a bilateral cleft also. So is there any difference in marking or something?
Initially, so the fork flaps were used to lengthen the columella,
Okay,
but
that is
Millard used to band those.
okay, but you have the C
Band
flap
the
in unilateral cleft also. Either you can do columnar lengthening or you can make the sill. What about the medial incision in bilateral cleft, bilateral Millard, bilateral cleft lip, Millard repair? Is it same as in the unilateral?
No, so we cannot take the back cut because the
Yeah.
columella itself will be narrow. So both sides we cannot take
that's
the
what
back
I
cut.
was asking.
Hence
No?
it will- Yes, sir.
Okay.
So it has to be
Okay. So my next question is, let us suppose some other patient than this and the same age group, and one side is very wide and one side is narrow. And I am a beginner.
Yes, sir.
I'm afraid of doing lip repair on both the sides. So which side should I do first? The narrow or the wider one?
Wider.
Wider. Then you can do the narrow also. Why?
In the narrower parts, sir, there already is a band of tissue there, which is since it is an incomplete cleft of the lip, so that band of tissue will not allow the premaxilla to protrude forward, and it sort of affect. I mean, it will
No,
not.
no. Yeah. Are you getting my question or not?
Yes, sir, I got
There
it.
is a patient of bilateral cleft lip. One side is very wide, one side is narrow. Okay. So
Yes.
I am afraid of doing the repair on both the sides. So which side should I do first? The narrow side or the wider side? And why? What is the reason?
Wider.
Okay.
So wider side should be done first, sir.
Why?
So that way at least if we can achieve a repair on the wider side, to the narrow side we can
Get some symmetry. We can, since there is no filter column, and we have to create the filter and create the symmetry. So once we
So-
do the wider side,
No, this is not the reason. You are right that we have to repair the wider side first, but this is not the reason. What happens if you repair on one side?
yeah, the
What
side
will happen to the other side?
It will keep growing and it will have unlimited growth.
Will it become more wider or will it
Yes.
become narrower, the
It will
other
become-
side?
It will become more wider because
More
the
wider.
side is
If you are already afraid of doing the wider side first, if you operate narrow side, the wider will become more wider.
Yes.
Then you will never be able to. Okay.
Yes, sir.
Okay. So my next question is, can you tell me the Cronin's principle of bilateral cleft lip repair?
Cronin's principle. What's to do with that rapid? When
You must have heard of the Cronin's principle, no? Have
yes.
you or you haven't? For unilateral lip, you know the criteria? Stephenson.
criteria, sir.
Okay. For bilateral
Yes.
also there is Cronin's principle.
Yes, sir. We have to reconstruct the lip of normal height, and we have to reconstruct
is-
symmetrical and scar-free cupids.
You are just telling the...
Cronin's principle, exactly.
Yeah, I'm asking about the Cronin's principle. This is basic. Height should be equal.
No, sir, we don't know, sir. Sorry.
The central lip segment should come from which segment? Medial segment or the lateral segment?
Hello.
Hello?
Hello.
Yes, sir.
So sorry, sir, we could not hear you, sir.
The central lip segment, it should come from the medial segment or from the lateral lip segment?
The medial segment.
Medial.
So the filter columns we create from the medial segment. We will take our incisions
along the
and according to filter.
The vermilion of the central lip and the white roll?
No, sir, there is no for the vermilion and this white roll. You'll have to take the lateral segments and bring it, align it medially. Only the filtral columns we'll take incision on the
No,
medial
I am
segment.
just asking about the vermilion of the central lip segment.
From the
Vermilion and white roll. They should...
from the lateral segment.
From the
Yeah.
lateral segments.
So, I mean, the Cronin principle you should know. Eh?
Yes.
Okay, what are the Cronin's principle? They are a must. As you know about the Stephenson's criteria, then this also you should know.
Yes.
Okay.
Yes,
Thank
sir.
you. That's all.
Thank you, sir.
Over to you, madam.
Thank you, sir. Now this is any panelist would like to answer the questions which are not answered by the students?
I think they answered all, and if there was any confusion, it was cleared there only. I think Shalabh sir cleared it that there only. Vibhuti sir, you have to ask,
Devi sir.
answer something. Devi sir.
Yeah, the questions I asked actually, 9-month-old, if patient is absolutely fit, there is no reason why we cannot do lip and palate together. Patient will have benefits from all sides, and it will become a single stage surgery with all the advantages of a single stage surgery. Second question I asked was about the step that must be done to prevent necrosis of the premaxilla, because when we are doing the bilateral anterior palate, we are taking the Vomeran mucosa to close the anterior palate. So we have to leave a strip of vomerine mucosa in the center so that whatever blood supply is there, it will perfuse the premaxilla. Otherwise, we are doing dissection from the nasal side and from the oral side, all sides being dissected. So the blood supply to the premaxilla can become precarious. The prolabium development, they said they answered properly. And the blood supply to the prolabium comes from the the columnar branches from the supralabial artery, not from the anterethmoid artery. Thank you.
Sorry, that question I also asked. They didn't reply. My team also didn't reply that. No? It was a common question. I forgot that. Yeah, it was the only question they could not answer there. So these are the columnar branch of superior labial artery, and there may be some contribution on the saphenopalatine also. Infraorbital artery, etc. That's it. Then
So
let us go to the
then-
moderators and judges.
Yeah.